Welcome to this clinical discussion titled The Lytic Lesion Mystery, a Diagnostic Chase. As you can see on this opening slide, we are following the case of a 44-year-old immigrant presenting with a pathologic fracture and widespread lytic bone lesions. At first glance, this presentation strongly suggests metastatic cancer, which is a common and concerning diagnosis in such scenarios. However, the text highlights that as the case evolves, striking biochemical anomalies begin to challenge that initial radiographic impression. This presentation is a collaborative effort featuring insights from various medical perspectives, ranging from residents to expert systems. A human user, Dr. Anupam, remains in loop, providing case inputs and moderating the discussion. We will journey through the diagnostic steps from the initial presentation to the final surgical outcome and long-term follow-up. It is a fascinating look at how clinical reasoning must adapt when the data does not fit the expected pattern. Before we dive into the specifics of the patient, let's establish our core learning objectives for this session. Looking at these learning objectives, we have divided our focus into two main pillars: clinical reasoning and management priorities. On the left side, under clinical reasoning, we aim to recognize the diagnostic pivots that occur when pathologic fractures and lytic lesions appear alongside severe hypercalcemia. We will also examine how phosphorus and alkaline phosphatase levels can fundamentally change our interpretation of a standard bone disease workup. On the right, the management priorities emphasize the urgency of treating a hypercalcemic crisis and identifying the biochemical red flags that mandate urgent parathyroid hormone testing. Finally, we will discuss how to anticipate and manage significant post-operative complications such as hungry bone syndrome. Understanding these goals will help us navigate the complexities of this case effectively as the details emerge. To ensure everyone follows the flow of the discussion, let's take a quick look at our session format. This slide outlines how our discussion will unfold, showing both the stages of the case and the different perspectives we will hear. On the left, you can see the 4 stages, starting with the initial presentation and concluding with the surgical outcome and long-term follow-up. On the right, the perspectives box explains the roles of our contributors. The doctor will reveal new objective clinical data, while the resident LLM offers a first-pass interpretation. The attending LLM then critiques the safety and sequence of the workup. And finally, the expert LLM synthesizes the most probable unifying syndrome. This multi-layered approach allows us to see how diagnostic decisions are refined at each step of the process. This structure is designed to simulate a real-world clinical round where different levels of expertizations contribute to the final diagnosis. Now that we have the roadmap, let's begin stage 1 with the patient's initial clinical presentation. As we enter stage 1, notice the details in the presenting history box on the left. Our patient is a 44-year-old man, a recent immigrant who has experienced 6 months of fatigue and a 7-kilogram weight loss. He has a complex medical history, including kidney stones, chronic kidney disease, and hypertension. Most strikingly, he presented with acute right clavicle pain after minimal trauma, which turned out to be a fracture at the site of a lytic lesion, as seen in the exam imaging box on the right. His family history is also notable for renal cell carcinoma, which adds a significant layer of concern for malignancy. Physical examination shows him in distress with visible deformity over the clavicle. Initial labs reveal a white cell count of 18,300 and an elevated creatinine of 2.3. These findings set the stage for a very concerning clinical picture. Let's look closer at the initial laboratory results to see what they reveal about his metabolic state. Looking at the hypercalcemic panel on the left, the results are quite dramatic. The serum calcium is very high at 14.3 milligram per DCE with a corrected value of 14.5. This is accompanied by a low serum phosphorus of 2.5 milligram per deciliter and a significantly elevated alkaline phosphatase of 621 units per liter. On the right, the negative screen box shows that several common causes of these symptoms have been ruled out. There is no monoclonal protein found on serum or urine, electrophoresis, and liver enzymes like ALT and AST are within normal limits. The combination of profound hypercalcemia and low phosphorus is a critical diagnostic clue that begins to narrow our differential. It suggests that the bone destruction we are seeing might not be from a simple metastatic process. This biochemical profile is the first major pivot point in our diagnostic journey. Now that we have these initial results, let's take a moment for an audience pause to reflect on the data. This audience pause presents several key questions for us to consider based on the data we have seen so far. The central question at the top asks, what is the most likely driver of this patient's bone disease? As we look at the three bullet points below, we need to think about how the combination of high calcium and low phosphorus narrows our diagnostic frame. We also have to weigh the family history of renal cell carcinoma against these biochemical findings. Is the malignancy still the primary suspect, or are we looking at something else entirely? Finally, we need to decide on the single most important laboratory test to order right now to confirm our suspicions. Take a moment to think about these questions and how you would prioritize the next steps in management. This is the point where our clinical reasoning must be sharpest to avoid unnecessary procedures. Let's see how our different clinical perspectives interpret this initial stage. On this slide, we see the reasoning from our three perspectives. The resident in the blue box suspects primary hyperparathyroidism with brown tumors or possibly parathyroid carcinoma, recommending an intact parathyroid hormone and PTH related protein test. The attending in the brown box focuses on immediate management, emphasizing hydration and calcitonin for the hypercalcemic crisis while warning against an early biopsy before parathyroid hormone results are back. They also suggest screening for familial renal cell carcinoma syndromes like VHL or HLRCC. The expert in the green box defines the core pivot. The combination of high calcium, low phosphorus, kidney stones, and lytic lesions strongly favors parathyroid hormone excess over myeloma. The expert's urgent next move is clear: measure the intact parathyroid hormone immediately. This consensus points us directly toward a parathyroid driven process rather than a traditional metastatic cancer. To deepen our understanding, let's look at a teaching pearl regarding the role of phosphate in these cases. This teaching pearl highlights two critical concepts. On the left, we see why phosphate serves as a diagnostic pivot. While many malignancies cause high calcium, they typically present with normal or even high phosphate levels. In contrast, finding low phosphorus in the setting of hypercalcemia and lytic lesions is a powerful pointer toward pathology mediated by parathyroid hormone. On the right, the slide discusses radiographic mimicry. It is vital to remember that brown tumors of hyperparathyroidism can perfectly mimic metastatic lytic lesions on imaging. This means we must always correlate what we see on an X ray or CT scan with the biochemical profile, specifically looking at parathyroid hormone, calcium, phosphorus, and alkaline phosphatase. Relying solely on imaging in this case could lead to a misdiagnosis of terminal cancer. With this understanding of the biochemical clues, we can now move to the next stage to see the results of the advanced testing. Stage 2 brings us the biochemical confirmation we were looking for. As you can see in the advanced biochemistry box, the intact parathyroid hormone level is a staggering 4023 picogram per milliliter, which is extremely high. Meanwhile, the PTH related protein is normal, ruling out humoral hypercalcemia of malignancy. Looking at the extended imaging box on the right, the PET-CT shows multiple hypermetabolic lytic lesions in the ribs, clavicle, and pelvis. However, it also reveals a 3.7 centimeter well circumscribed mass in the anterior mediastinum. Interestingly, the standard sestamibi scan of the neck showed no abnormal trapping, which explains why the initial focus might have been elsewhere. This massive elevation in parathyroid hormone, combined with an ectopic mass, completely changes the diagnostic landscape. We are no longer looking for a primary bone cancer, but rather the source of this hormonal surge. This brings us to another opportunity to pause and consider the implications of these findings. We have reached another audience. Pause with some very specific questions. The main query at the top asks how a parathyroid hormone level of over 4,000 reframes the entire etiology. This is an extraordinary value that should immediately trigger certain suspicions.
We also need to consider the significance of that negative neck sestama B scan.
Why did it fail to show anything in the neck? And how does that relate to the mass found in the mediastinum? Furthermore, does the size of the 3.7 centimeter mediastinal mass increase our suspicion for parathyroid carcinoma rather than a simple adenoma? Finally, we must decide on the priority. Do we need more imaging for localization, or is it time for immediate surgical planning? These questions are vital for determining the safest and most effective path forward for the patient. Let's examine how our clinical team reasons through these new high stakes data points. The reasoning at stage 2 shows a clear shift in focus. The resident now pivots toward ectopic parathyroid carcinoma, noting that the extreme parathyroid hormone levels and the size of the mass are highly suspicious for malignancy. They are already requesting a thoracic surgery consultation. The attending in the center warns against a biopsy to avoid seeding and emphasizes the need for an en bloc resection. They also suggest advanced imaging like 4D CT for precise localization and identify a high risk for post operative hungry bone syndrome. The expert synthesizes all of this, conferring that the case has definitely flipped from a suspected metastatic cancer to a parathyroid hormone driven bone disease. The expert also notes that the mediastinal location explains why the initial neck imaging was negative. The diagnostic journey is nearing its conclusion, but the surgical challenge is just beginning. We now move to stage 3 to look at the tissue diagnosis and final localization. In stage 3, we get the definitive tissue and imaging results. On the left, the clavicle biopsy findings are listed. Multinucleated giant cells in a fibrous background with hemosiderin deposition. This is perfectly consistent with a brown tumor, and importantly, no malignant cells were identified in the bone itself. This confirms that the lytic lesions are a consequence of the hormone excess, not a primary cancer. On the right, a repeat cystomy B scan that included the chest confirmed avid isotope localization within the 3.7 centimeter anterior mediastinal mass. This solidifies the diagnosis of an ectopic hyperfunctioning parathyroid gland. We now have a clear target for intervention and a much better understanding of why the patient's bones were failing. The mystery of the lytic lesions is solved, but the patient still faces a complex surgery and a difficult recovery. Before we proceed to the operating room, let's consider the surgical priorities. This final audience pause focuses on the preparation for surgery. We need to decide on the best surgical approach. Should the resection be a simple debulking, or is a more extensive en bloc resection necessary given the suspicion of carcinoma? We also need to think about what intraoperative tools can confirm that we have successfully removed the hyperfunctioning tissue in real time. Finally, what biochemical baselines must be established before the first incision is made? These decisions are critical to ensure a successful outcome and to minimize the risk of recurrence or complications. The transition from diagnosis to management requires a shift in thinking toward technical execution and post-operative safety. Let's see how our clinical experts synthesize these final preoperative considerations to ensure the best possible care for this patient. This will help us transition from the diagnostic phase into the actual surgical intervention. As we prepare for surgery, our experts provide a final synthesis. The resident suspicion for carcinoma has risen to 75%, and they emphasize the importance of intraoperative parathyroid hormone monitoring to confirm a drop of more than 50%. They also stress the need for high-dose calcitriol after surgery. The attending demands an en bloc resection to ensure clear margins and recommends genetic testing for specific mutations like CDC73. They also reiterate the severe danger of hungry bone syndrome due to the high alkaline phosphatase and parathyroid hormone levels. The expert concludes that the biopsy and chest imaging have definitely reframed what looked like widely metastatic disease as advanced metabolic bone disease. This final synthesis provides a clear roadmap for the surgical team to follow. Now, let's move to stage 4 to see the actual surgical outcome and the pathology results. The surgical outcome slide reveals both the success of the procedure and the anticipated challenges. On the left, you can see a dramatic intraoperative parathyroid hormone drop from 4,166 down to 261 picogram per milliliter. By postoperative day 5, the level was within the normal range at 87. However, the patient did experience the expected complication of profound hypocalcemia requiring intravenous calcium and high-dose calcitriol, a classic case of hungry bone syndrome. On the right, the pathology results are detailed. The mass showed cellular atypia and nests of tumors within the fibrous capsule. Immunohistochemistry was positive for parathyroid hormone, cytokeratin, and chromogranin, with a key 6-7 index of 7%. This led to the formal diagnosis of ectopic parathyroid carcinoma. While the immediate crisis was managed, The diagnosis of carcinoma means the patient's journey is far from over. Let's look at the long term course and the risks this patient still faces. The long term course for this patient highlights the aggressive nature of parathyroid carcinoma. 5 years after the initial surgery, the parathyroid hormone level began rising again, reaching 368 picogram per milliliter. New imaging identified a 1.3 centimeter mediastinal lesion, indicating a recurrence. Unfortunately, as noted on the left, the patient was lost to follow up shortly after this recurrence was identified. On the right, the recurrence profile shows that parathyroid carcinoma has a recurrence rate of approximately 50%. It typically manifests as a gradual increase in calcium and parathyroid hormone levels, which is why lifetime surveillance is absolutely mandatory for these patients. This case serves as a sober reminder that even a successful initial surgery requires vigilant long term monitoring to catch potential issues early. Now that we have seen the full clinical arc, let's synthesize the diagnostic timeline to recap the key lessons learned. This diagnostic timeline beautifully summarizes how our reasoning evolved throughout this complex case. We started with an initial presentation of a pathologic fracture, lytic lesions, and weight loss, which naturally led to a high suspicion of malignancy like renal cell carcinoma or myeloma. The first major pivot occurred when the laboratory results showed a calcium of 14.5 with low phosphorus and high alkaline phosphatase, shifting our frame to parathyroid hormone mediated bone disease. Localization followed with a massive parathyroid hormone level of 423 and the identification of a 3.7 centimeter mediastinal mass, confirming an ectopic parathyroid neoplasm. Finally, the surgical resection confirmed carcinoma, followed by the expected post-operative Hungry bone syndrome and an eventual 5-year recurrence. Each step in this process was driven by a careful re-evaluation of the biochemical data against the imaging findings. To further solidify these concepts, let's review a teaching pair on the great mimicker, round tumors. This teaching pearl focuses on brown tumors, which we now know were the cause of this patient's lytic lesions. On the left, the slide explains their radiographic appearance. They show up as well-defined lytic lesions on X-ray and CT and are hypermetabolic on PET scans. This makes them virtually indistinguishable from metastatic cancer based on imaging alone. On the right, we see the pathological clues that help differentiate them. The presence of multinucleated giant cells and hemosiderin in a fibrous stroma is the classic histological finding associated with osteitis fibrosa cystica. It is crucial to remember that these are non-neoplastic lesions and will typically regress once parathyroid hormone levels are normalized. This highlights the importance of not rushing to a diagnosis of terminal cancer without a full biochemical workup. Next, we will take a closer look at the metabolic storm that often follows the treatment of such severe cases. Hungry bone syndrome is a significant postoperative challenge, as we saw with our patient. The pathophysiology box on the left explains that the sudden withdrawal of very high parathyroid hormone levels causes an abrupt shift from bone resorption to rapid bone mineralization. This bone hunger pulls calcium, phosphorus, and magnesium into the skeleton much faster than they can be replaced. On the right, we see the risk factors for this condition, including high preoperative alkaline phosphatase, extremely high parathyroid hormone levels, large tumors, and vitamin D deficiency. All of these factors were present in our case. Managing this syndrome requires aggressive intravenous and oral repletion to prevent dangerous levels of hypocalcemia. It is a predictable but intense metabolic storm that must be anticipated in any patient with severe hyperparathyroidism. With these metabolic lessons in mind, let's summarize the key management priorities for such cases. As we look at the management priorities for parathyroid carcinoma, the surgical approach is paramount. As shown on the left, an en bloc resection that includes the ipsilateral thyroid lobe and surrounding tissues is mandatory if carcinoma is suspected. It is critical to avoid rupturing the capsule to prevent the seeding of tumor cells, a complication known as parathyromatosis. On the right, the slide emphasizes the need for lifetime surveillance. Because recurrence can occur many years after the initial surgery, patients require monitoring of their calcium and parathyroid hormone levels every 3 to 6 months, along with periodic imaging. This long-term commitment to follow-up is the only way to catch recurrences early and manage the disease effectively. These priorities ensure that we are not just treating the immediate crisis, but also planning for the patient's long-term health. We now conclude with a final synthesis of this remarkable case. This final case synthesis reminds us that the outsider in this mystery was an ectopic parathyroid carcinoma masquerading as metastatic cancer. The central lesson here is that in any patient with lytic lesions, biochemistry, and specifically the finding of low phosphorus, is the essential key to unlocking the true diagnosis. Successful management of this patient required a multi step approach, bridging the initial hypercalcemic crisis, achieving precise mediastinal localization, and carefully navigating the profound metabolic swings of post-operative hungry bone syndrome. The 5-year recurrence we observed serves as a stark reminder of the aggressive potential of this rare malignancy and the absolute necessity of lifelong surveillance. Always remember to look beyond the imaging and let the biochemistry guide your diagnostic journey. Ask for the parathyroid hormone level, screen for metabolic markers, counsel your patients on the importance of follow up, and provide the comprehensive care they need.